Hi, welcome to everyone, and thank you so much for coming to the panel on AI, healthcare, and the law. This is a panel organized by Leiden University, and I am Eduard Fosch Villaronga, and I am currently working at Leiden University at the eLaw Center for Law and Digital Technologies. I normally focus on healthcare, robotics, and AI technologies. And I've been working a little bit on the past. And today I am going to be your moderator. And we decided that instead of having presentations, what we want to do is to take the opportunity to have a conversation between different experts coming from different backgrounds, policymaking, research, and also the industry, to talk about a little bit what are the challenges that AI poses in healthcare. And that's what we are going to try to do. So the speakers are invited to cut each other and to just jump in the different conversations. And I also would like to invite the audience in here if you have any questions. We have the mics though, so that doesn't mean that we don't want you to participate, but we thought that we wanted to have like a little bit more of a cozy format in here. So we will start with a very short introduction of who we are, and then we will just jump into what is the topic of the panel. So, David, if you want to start.
Hello. First of all, thank you very much for inviting me. Many thanks. It's my first CPDP conference, and I'm enjoying every bit of it. So it's a great pleasure to be here. My name is Davit Chokoshvili. I'm a former academic, I would say. I've done my PhD and postdoc right here in Belgium at the University of Leuven. But right now I'm working for a genomics company called Megeno. Company is based in Luxembourg. My role is regulatory affairs and bioethics manager. So what the company does is essentially helping individuals to store their genomic data. Megeno stands for My Genome. And reuse it over the course of their lifetimes when a need arises, medical need arises. And essentially our slogan is turn your genome into lifelong assets, and that nicely summarizes what we do. In terms of my interest in this conference, my primary interest lies in data protection and GDPR-related issues, but apart from that, my company does a little bit of work around AI, in particular predictive diagnostics in genetics, so hence the relevance for this particular panel. Thank you.
Thank you, David.
Hello everyone, and my name is Cristina Andersson, and also I'm very happy and thankful to be a part of this panel. Thank you, Eduard. So I've come from Finland, and I'm an entrepreneur and a consultant. And my topics, well, they are quite wide range, but lately I have been working a lot with AI and robotics, and also working as a specialist, for example, EU Commission, EU Parliament, and different committees in EU, and different ministries, and the Parliament also in Finland. And one of my biggest projects is still the National Program for AI and Robotics in Healthcare and Well-being in Finland, together with the Ministry of Health, Social Affairs and Health. And I think that is my main interest also for this panel. Thank you.
Hello, everyone. Thank you so much also for inviting me. This is also my first time at the CPDP, and I think there is always a first time. Yeah, so my name is Vibeke Binz Vallevik. I'm from Norway. I work in a company called DNVGL. We're actually an independent foundation, mainly working as we have certification schemes and accreditation and take third-party roles when it comes to enabling critical technologies and so on in many different sectors. I'm from the research program in precision medicine. So we work to enable clinical uptake of precision medicine. That's really what we do. And I am, through that, I am managing a project called BigMed in Norway, which is based at the Oslo University Hospital, at the Intervention Center, which is the department that tests new technologies and sees how they work. So that is, I think right now, the biggest precision medicine initiative in Norway. It's a national lighthouse project funded by the Research Council. And we have 20 different partners, and both in academia, IT, the clinic, and also industry. And we're looking at what are the barriers for the clinical implementation of precision medicine. And for those of you who wonder what this precision medicine is, to us that is the model where you have a different approach to the patient, more looking at individual characteristics than putting people into diagnosis groups. And in order to do that, you need better data. You need good molecular diagnostics, like genomics, for instance, which is something we do a lot. And you need better data-driven decision-making systems. So that's where the whole AI comes in, I guess. So my interest here will be, I guess, a wider scope, but focusing on what is needed to actually start using these things in a clinic, so getting it from bench to bedside.
Awesome.
I'm Robin Pierce. I'm at Tilburg Institute for Law and Technology in the Netherlands. I am interested, I have a background in health policy and law, of course, and I am interested in AI in medicine. I specifically focus on translational issues, as Vivek has said, from bench to bedside. And so there are many different strands that have to be considered in that translational process. Today we'll be talking about data protection issues, but beyond that, because a lot actually ties into data protection, as well as medical decision-making and so forth. So research ethics, et cetera. So I look forward to a very robust discussion with you today.
Hello, my name is Marcello Ienca. I'm a senior researcher at ETH Zurich in the Health Ethics and Policy Lab. I'm also involved in a few international organizations' activities related to emerging technologies, such as the OECD group on the steering group on neurotechnology. My research revolves primarily around ethical, legal, and social issues in artificial intelligence and advanced biomedical technology, both in terms of empirical research on ethically aligned design and the user-centered approaches to technology development, but also in terms of technology assessment and ethics assessment. So we do this in a very multidisciplinary way, bringing together expertise from various domains such as computer science, engineering, ethics, law, and the social sciences. And I'm very much looking forward to this discussion.
Awesome. So why are we here? We've seen a lot of increase of productivity and resource efficiency in industry and retail sectors, and in a way it is expected to see some sort of similar transformation when it comes to healthcare. But of course, the application of all these technologies in a particularly sensitive area is not as straightforward as some might think, right? Some of these technologies, they might vary from many different sort of applications, and their potential might be very vast. And one of the things that drives my research is, and I was sharing with them before, is that my mother is a breast cancer survivor. At the time, they didn't really have any AI predictive system in trying to understand or to diagnose her disease, but she was one of the very lucky ones that got to be detected at a very early stage, and thanks to that, she didn't have to go to chemo, just like very focused radiation and so. And of course, once then we went through the process, the doctors were asking her, like, would you like to give like some of your data, like some of the things that we're doing? And she was not that much familiar with the data protection issues, even if I talk a lot about that, no. But she totally said, yes, I want to give this because I think that this is good and we could help a lot of women with this. And But of course, when then you see like all these developments on technology, and then you have all these support systems that process vast amounts of data, and they have health-related outcomes, we're not just talking about data, right? We're just also talking about the safety of the patient. So we're here today, like bringing like from different visions, also like what are the opportunities that this offers, but also like to understand what is actually the challenges and like how do we see that. And we will start first with Cristina, and she will be talking a little bit like from the point of view of the policymaker, like how the Minister of Healthcare in Finland like sees the adoption of these and what are like the main barriers. And with her, then we will be moving a little bit like to different speakers to map a little bit like the main questions that we have. And then we will continue with Davit and Vivek zooming in some of these issues. So Cristina, the floor is yours.
Thank you so much. Yes, we started to build the program about 3 or 4 years ago, and usually we Finns used to say that when we start something, we are going to say that, okay, we are going to be the world's best in this and that and that. But when we started this program, we saw what Eduard was talking was about, that it's actually very little that we knew about 3 years ago. And 3 years ago, there were things nobody were, well, we are talking about now, but not then. And we said that, okay, this is something that we need to learn about, and not to be the best, but learn about. And so we started to learn. And quite soon we realized that we need to focus. And so we found 4 areas where we could think about how we can use robotics and AI in healthcare. And one of them was hospitals and logistics. And of course you know about the hospitals that the minimally invasive surgery has been going on for a long time. But there are also many things that can help the nurses. And there was a study made in Finland that 60 to 80% of nurses' working hours time go to logistics and IT work. So when we need more patient or human-centered care, so we actually need something that could free the hands for those people. And for example, the robots in logistics inside the hospital, they are very much developed already, and they are the price has come down. And in Vienna, there is a hospital where 90 robots take care about 98% of all logistics. So this is really an opportunity what we should, and we are looking at it. But I'm sorry to say that we are not the world's best in Finland, but we are moving forward quite slowly in this also, although there is studies that show and examples that show that it really helps. Of course, there are many other technologies that can help nurses, and they are being used. The other one is medicine management. And I don't know if you know, but it was, for me, it was surprising to know that from leukemia patients who really need to take their medicine in time, so only 23% of them take their medicine in just the right time. So here are technologies already. For example, there is a Finnish company called Evondos. They are making a drug delivery robot that delivers the medicine at the right time. And that has helped a lot. Not only the patient, but also the home care personnel. The one problem for the home care personnel is that in rush hours, for example in Helsinki, it is impossible to get from one place to another in time. But with the help of this robot, they have been able to schedule their visits in a new way, because in the morning rush hour, they don't have to go because the robot is taking care of the medication and they can take another time. The third part is rehabilitation and well-being coaching. And this well-being coaching is a little bit less because chatbots and these kind of technologies, they have been taking those huge leaps only in 1 or 2 years now. So we are just starting to use, but we have already very good experience, for example, helping people with mental health problems with the help of a chatbot. But then rehabilitation, for example, there are 14,000 people who suffer from brain stroke or brain injury in Finland every year, and we have been able to help them remarkably with the help of a robot-assisted rehabilitation. But this means also that there will be a new organizing of work, because in former days, without the robot, there were 3 physiotherapists working with 1 patient in this rehabilitation session, and now there is a robot and 1 physiotherapist. But there will be more work for physiotherapists also in the future, also with the robots, because they are very much needed. And the 4th part, and the most focused part, is care at homes. In Finland, we regulated 2013 that everybody must be taken care at home as long as possible. And actually, I was last summer listening to a forum of silver economy. There was a specialist from America who said that they are really focusing at care at home because the most dangerous place for a sick person is a hospital. So they have also been giving chemotherapies at homes. So this is something that we are really working on, and of course the technology at home, that is the most sensitive and most critical and very difficult to find. But for example, there is a Swedish robot that feeds you. It's called Bestik. And there was also a Swedish study that says that about 40 to 60% of those people who need feeding help in home care, so they suffer from undernutrition because the actual time for eating or feeding is about 4 to 6 minutes, and nobody can get, nobody can eat in that time enough or good enough. So, and then in the matrix we have AI and data and analytics, and this is something, and the program is, we have some information about it in English, so if you like to Google, so please do, but we have made quite advancements already in 3 years, and I'm still working it, and my task now is to make the program international, so if you are interested to share ideas, because we want to learn more, and we also want to tell everyone what we have done and what we have achieved. I think this is a great opportunity not only to make a quantum leap in well-being and health in Finland and the world, but also a great opportunity for companies to make better business and to, with the help of their business, to create a better world.
And I think that Marcello and Robin have been both working a lot on also the legal and ethical challenges of rehabilitation robotics, like both for physical and also for therapeutic purposes. Marcello, can you tell us a little bit more like about the work of Develor and also a little bit of what are the main challenges that these focus areas that I assume that are in our agendas pose to all of us?
Sure. So rehabilitation robotics is really one of those domains where artificial intelligence is showing a great potential to assist people in need, especially people with physical disabilities. In the last decade, we have seen stupendous progress in various areas of wearable robotics and other forms of assistive and rehabilitation robotics, including technologies at the human-machine interface that enable a more stable and reliable connection pathway between a human being and an external computer device. Eduard mentioned the Cybathlon, which is a competition organized every 4 years by ETH Zurich, in which people with physical disability compete. And the task consists on everyday tasks, so activities of daily living, such as navigating an environment with obstacles or people with, for example, artificial limbs, with artificial arms, that have to pick up objects from a table and move them to another place. So all activities that sound very easy and easy to perform for most people without disabilities, but they are big everyday challenges for people with disabilities. And the aim of this competition is really to generate awareness about the needs of people with disabilities, and also try to accelerate technological development that can improve the development of technologies for these people in need in a manner that empowers end users. And I think this is really a key concept. Technology is important, but is very important to make sure that technology is not developed per se, but in order to improve the lives of people. And therefore, one of the paradigms of the Cybertron is precisely to have end users and the developers work alongside each other, work collaboratively together in order to basically include as much as possible the wishes and needs of end users into product design. That's an approach called user-centered design or patient-centered design, which is showing a great potential for making sure that the technologies we develop are actually calibrated on the needs of their end users, and they have a greater potential to empower them and have a good life. Another area that has seen a lot of improvement in the last few years that I'm particularly interested in, and this is also one of the various competitions that we have within the Cybertron, is that of brain-machine interfaces. This is a newer field, even though the basic research in this domain started in the 70s. But in the last few years, we've seen very rapid development in developing technologies that can establish a direct connection pathway between the human brain and an external computer device, which is an extremely important communication channel for people who are not able to interact with the external world in any other way. So, for example, people with tetraplegia or with advanced stage of amyotrophic lateral sclerosis. And in this case, this is really showing a potential to reestablish some minimal form of communication with the external world. So there is a lot of potential, but there are also a lot of challenges that we need to address. And one of these challenges is precisely how can we make sure that we incorporate the wishes and needs of end users reliably in product design? How can we make sure that we incorporate ethical consideration early on in the design and development phase of a new technology? So how can we make sure that ethics is conducted in a proactive and not just in a reactive way? We have seen that in many other domains of technology development, that first we develop something, then we find out that something doesn't really work that well. And then the ethics kicks in, and we try to fix a problem that has already emerged. What I'm advocating is rather an opposite approach in which we are proactive and we incorporate these ethical considerations early on in product design through a collaborative work between ethicists and lawyers on the one hand and product developers and engineers on the other hand.
Yeah, it totally makes sense. In many occasions, it seems that it is kind of a checklist exercise. It's like, okay, like how can we make it that we just like very quickly get away with it? No, but in a sense that like bringing all this at the very early stages, it is very important, and broader ethical considerations, but also when we see the privacy by design principles and also all these other considerations that are crucially important. A lot of these technologies were not processing data at some point, but now like when we are thinking about prosthetics, and so like the potential that some of these technologies now have like of monitoring, and so it totally changes the paradigm of what we had before, and now that it is actually a technology that is processing data. Robin, according to you, like what do you think that are like the main challenges that all these technologies poses to us, or that you have identified throughout your immense work over these years?
I kind of anticipated that question. I'm going to zoom out a little bit and speak a little less specifically than my colleagues here have spoken, and talk about some of the policy challenges of AI more generally, broadly, thinking long-term, thinking translationally, getting from bench to bedside. And I'm going to focus on 4, and I'm going to do this very briefly because there are 4. And the first one, as actually my colleagues have referred to, is what is exactly our starting point? And are we actually looking at AI in medicine as we've got this great new technology, what can we do with it? Oh, here's an application, here's an application. Instead, should we be asking the question, what are the pressing needs of healthcare today? And as a earlier speaker pointed out, there are several. Among these are the aging demographic, which is widely acknowledged, healthcare inequities, rising costs, both of drugs, treatments, and other kinds of treatments, skill and staff shortages, and I have another word to say on that a little bit later, and various pricing models, and I'm sure you can think of others. But there are pressing needs that are widely acknowledged that are actually burdening healthcare systems to a very serious and concerning degree. To what extent and how can AI actually assist in addressing these issues? That's the question. And part of translation puts a sort of discerning eye on this process from technology development to application. Is everything that's exciting and fancy the right thing to put into the healthcare setting? So that's my first point. The second point, challenge that I want to focus on is the sort of process of AI. One of the much discussed potential applications of AI is in evidence generation. There's even discussion of AI as replacing randomized clinical trials. We all know that randomized clinical trials, RCTs, are very time-consuming, very costly, can go on for years and years and years, and that's very much criticized. And AI offers the opportunity, particularly with certain types of programs, where you can collect the data, process it, reference others, and put out an output, either in diagnosis, treatment, prognosis, treatment recommendations, and so forth. So there's a substantial potential benefit to be had here. But what happens, what is lost when we collapse the research enterprise with the care enterprise? So we're actually merging the two. As all of you know, as everyone I'm sure in this room knows, we have a very sort of extensive and highly structured research oversight framework. For example, including the clinical trials directors, research ethics going back for decades. So this is a serious concern. So now this no longer falls under that oversight that we have clung so carefully to. What are the implications of that? What's lost and what's gained? The third point I want to make is more of a procedural one, a political one, you might say. It has to do with trade-offs. So this is the Data Protection Privacy Conference. So one of the acknowledged trade-offs for purportedly improved health outcomes, to what degree remains to be seen, is better health outcomes, et cetera. But there's a trade-off perhaps with privacy and data protection. And the question is not so much, the question is very much, what trade-offs are we willing to make? But I want to actually put forth that is as important, not only what trade-offs we're willing to make as a society, communities, but how do we make those trade-offs? What is the process? Who participates in the ability to make those trade-offs? And so when we have these innovative new programs, national programs, where people's data is automatically included in certain databases, and we think about, what are the opt-out options, et cetera. These kinds of things become important depending on what the process was in discussing the trade-offs. My fourth and final point, Edward, is goes back to the previous discussion just a bit in terms of the use of robotics, which has enormous potential and promise in the healthcare setting. Very exciting things are being done. And I'm going to look at, thank you. And I've started to look at this in terms of this concept called task shifting. Where do we make the decisions of which tasks should be allocated to robotics, and which should not? And one of the policy questions, zooming back out, is, are these task shifting decisions that are being made, are they short-term? Are they designed to address a specific problem in a specific context that has arisen, and we need a fix now? Or is it a long-term solution? Are we going to dispense with training, seeking to train a sufficient healthcare staff personnel in different areas? What is the trajectory for task shifting to the use of robotics? And those are my 4 general policy challenges.
I actually still remember that video that you showed me once. That was really moving. So basically, we were at a conference together with Robin, and she was actually also wondering about this task shifting. And there was this person that was in the doors of death, and then there was like a telepresent robot that with the doctor behind it, and I think that it was the daughter with him. I don't remember. Yeah, so they were like the father and the daughter, and then the telepresence robot, and then through the telepresence robot, the doctor said, "You're going to die," basically. And then we were wondering, actually, like, it's not only task shifting, but also what questions are we really allowing ourselves? Like, because in this case, it's a telepresence robot, right? Is the doctor actually there? But in a way, it's not there. It's through the robot technology. And this poses a lot of questions in actually the role of all these devices. Like, are they being used, for instance, the Da Vinci also teleoperated? Like, is this an extension or not? And actually, something that was actually being raised in the panel before, like, is this desirable, right? Thank you, Robin, for this. These also questions, like when it comes to data protection. I was thinking now, like with Davit, for instance. No, like you guys are working with genomics data, which is very sensitive data. How, because now you come from the from a company, right, side, like and people in the audience might wonder, especially privacy specialists, like how does a company like you ensure that you manage all this data in a responsible manner? And I don't know if you could share that with us.
Well, thank you very much for this question. It's super relevant. So as you correctly mentioned, genomic data is extremely sensitive data, and there are various ways in which it could be misused. So just yesterday morning, we heard in another panel in the other building that many individuals are concerned about potential discrimination by insurance providers based on genomic data. Another concern often raised is discrimination by employers, but really it goes beyond institutional considerations. You might have discrimination or other negative implications at the personal level. For example, in terms of selecting your romantic partner, do you want to spend the rest of your life with someone who has a very high risk of developing some sort of severe neurodegenerative disease or cancer or whatever? And of course, there are major psychosocial implications for the individuals themselves who know that they're at risk of something like this. So there are lots of sensitive matters around this issue, and also I should mention there's this emerging issue of commercialization of genomic data. A company profiting off of your genomic data, which is very sensitive and very personal. Now I must say, not all commercialization prospects are necessarily detrimental. For instance, you could have drug development, which is arguably a good thing, but even there, questions can be raised with respect to how the informed consent was solicited, whether the use was consented to by the patient, and whether security and other considerations were taken into account. And I have to say, unfortunately, private companies as a group don't have a particularly good track record in this regard. There have been quite a few controversial cases in the past, and we as a genomics company are very much aware of this, and we're trying to set up a system, a long-term strategy that enables us to tackle these issues. So we're implementing an innovative solution that we call governance and oversight structure, and it's going to have two pillars, an advisory pillar and an assurance pillar. On the advisory side, we're going to have what we call ELSI board. ELSI stands for Ethical, Legal and Social Implications. Marcello already mentioned this term. This will be independent, mostly academic experts from legal, policy and other areas. And they won't have any share ownership in the company, so they should be able as such to provide objective advice. But we're not looking for just an optional, unenforceable, non-binding advice. There are lots of guidelines out there. Marcello recently published a paper which reviewed AI guidelines around the world. I think there are almost 100. If you did a similar study on genomics, probably similar number of studies, guidelines would be identified. There are plenty of them. We don't want something optional and non-enforceable. So to that end, we're very happy to have an external auditor on board, Ernst & Young, their Luxembourg branch, and here their reputation is really at stake, so they are going to certify whether we're compliant to ELSI board's recommendations. So there's really accountability involved, and we have very little flexibility. We want to communicate this message with the external community, be it clinicians, be it geneticists, or the general public, that we want to do this the right way, and this is the institutional design we are going for because of that. So this is in the design phase, but at the end of the year, will be fully implemented. I forgot to mention that the assurance side, Ernst & Young, will also be certifying our GDPR compliance, which is very important, but it's only, I would argue, one aspect. It's not sufficient to fully restore the trust in private companies that has been shaken over the past few years. So if I happen to be here next year, if I get to be invited, I'm sure I'll be able to share meaningful progress with you, because at the end of the year, this mechanism will be fully set up and operational.
Yeah, and we will be very happy to hear actually what are the concrete mechanisms that you are applying to really make this happen. I think that one of the questions is this translational problem actually of not only from the implementation side, but also from these general principles, how do you actually ensure that this is done in a way that it's also meaningful, not only for compliance purposes, but of course from the user side, right? That is actually their data, that it is they ensure the access and that is actually done in a way that that the users are of course rights are respected, right? Vivek, you in your research and in your company, you're also collaborating a lot with research, and now you are under this project, and you guys are working on clinical AI, and I think that you also identify certain barriers that are kind of pressing, and I don't know if you can share also that with us.
I can.
Definitely.
Thank you for that. Yes, that's been actually the main focus of our project, is to identify the barriers to implementation of precision medicine and see what we can do to move them. So the way we've been working is we've set up with this very clinically focused. So we have 3 different clinical cases that we work through. And then we have sort of going across, we have a legal group, we have an infrastructure group, and we have all the technical add-ons. So it's a very multidisciplinary team. And the way we work is we experiment and we test and we fail and we learn. And from what we do, we try to derive more generic learnings. And I just wanted to tie back to what you said, Robin, about this. The first point you said on the needs, right? What do we need to develop? So when we started our project a few years ago, we went out to our clinicians and we said, okay, this is awesome. What do you need? Something cool, AI, and we can make this and this. And they just looked at us blankly and said, guys, we still use Post-its in our meetings. We're not there. We don't even have access to our data, in the medical records, right? So they're at, I don't know, how many of you people in this room still use a fax machine? Because we do at the hospital. So the technical debt that we have there is quite substantial. So we had to start with the needs, and it was a lot about access to data. That was the first issue. And one thing is you want to get access to data to develop a solution that is difficult. You can do it in a research setting, so you have the whole ethical committee and a way to go through that. What we saw, oh, hello.
It's going here? No, we lost you.
Oh, here I am. What we saw happened was that when we started our project, GDPR came sailing in, and that had a huge effect on access to data and the way people would react to that. So it actually put everything on hold. It froze all research activity, all new research activity for a very long period of time while people were trying to figure out how do we do this thing. And the strange thing is that we've had privacy laws for years, since the 90s. It wasn't that new, but still it has a very big effect on people, and I think that ties back to also organization, which is one of the big barriers and big challenges we see. So that we have an organization set up with privacy officers, we don't have sort of the other side of the coin. So if the privacy officer is tasked to look at privacy matters, you have no one arguing the case for the benefit of doing it, or at least in our organization. So that was a big issue. We had an example of this. This is what we've been seeing a lot, is this tension between privacy and actually delivering adequate healthcare when it comes to especially AI solutions and genomics. We had one case where we made in our project a solution to share genomic data, genomic variants. And I have to just add to what you said, David, genomic data doesn't necessarily have to be sensitive. It can be, the whole genome of a person is absolutely very sensitive, but if you pick out one part, one variant, how it's classified, that is as close to anonymous as you get. Still, in Norway, when we developed this solution, the Directorate of Health, they interpreted it with GDPR that this is personal data, so it's not anonymous, it cannot be shared in this way. You need consent to share this. And what happened in Norway was actually that there was a case with a few breast cancer patients that had removed their breasts after being told they were at risk. Turned out this laboratory interpreted this variant differently from everyone else. So they hadn't shared their data. That's why they misdiagnosed their patients. And they were fined. So they were fined because they didn't share data due to privacy issues, but then they still broke the law. So it's a way damned if you do and damned if you don't. And those are one of the things that we're trying to sort of figure out. Where should that balance go? What do we as society think is the right way forward there? So that was one example. I have plenty of others. How much time do I have?
It kind of goes very well together with what we are saying about the trade-offs. And you want to say something or reply?
Yeah, and feel free to jump in. Exactly. I'll just continue. And when I talked about access to data, and in healthcare, I think that's particularly difficult. In order to make good AI solutions or use big data solutions of any kind, we need a lot of data. And very often, the data we have is from a research setting. So we have a specific cohort of patients that have been selected very carefully. And that's not always representative of real life, right? So how do we know then when we train an algorithm in one setting that is very sort of synthetic and not real, how do we know that it works once it's out there? And we have, so patient safety and the whole trust in AI is a big issue that we're discussing. The MDR, the medical device regulative, and the IVDR, the in vitro diagnostics regulative, they're going to incorporate all software that has critical impact on patient decisions very soon. That is great, so you can have a CE marking on a product. What is a challenge is that that CE marking will tell you that this product does what it claims to do. Basically, we've tested that and it's okay. But in the clinic, you will almost, and for very many purposes, you will need to use it in a different setting or in a different kind of data. The patient may be different. If it's a university hospital, maybe you have sort of more critical cases. It's just a different population. And how do we know then that it still works good enough? How do we validate that? Just as an example, what we see happening right now is that in the clinic, many producers, the companies, they will mark their product with research use only, sell it, and then in the clinic, they will take it and use it in the clinic because that is what's available. So for instance, the genomics pipeline at Oslo University Hospital, I believe, has 48 software components, all research use only, used in diagnostics every day. And how do we know that it's safe and good enough? What mechanisms do we need to have in place to support the clinicians to make the right decisions? So that's, yeah, something I think is very interesting.
Yeah, I think I'm very scared. Well, because in a way we're saying, well, we have in place regulations, but they might pose also like barriers, like in a sense, like, well, there are like more pressing interests here, like that may have to prevail, like to avoid that, no? And then sharing data might be considered a good thing in many instances, because then we assure that the safeguard baseline, it is respected by all providers. No, and you say like, well, at least like this we have. But then we're talking about that all these other part of regulations concerning like CE marking and the compliance with the standards, which assures that yeah, product is safe. But for instance, there's the growing interest in saying, well, but if these devices, these products are going to have learning capabilities, adaptive behavior, and they're going to learn over time, and they are going to learn sometimes with interaction with patients and so, and then you say, well, how do we ensure that this, what you certified is really okay over time, right? So in a way, like, yes, and then there's the other side. You say like, yeah, whatever you're doing, it's fine, but then it may be possible that then the doctor said, like, yeah, but that is so useful for this other thing, and I'm just like going for that. I think that you wanted to jump in, David.
Yeah, so Vibeke made quite a few very good points, so I'll just quickly respond to that. First of all, a minor clarification. Yeah, of course, I was referring to whole genome data or broader genomic data rather than specific mutation or variant, because that is, I'd still argue in terms of psychological and psychosocial implications, still very sensitive, but not identifiable, and certainly the anonymity issues are not raised to the same extent. With respect to data sharing, that was a very insightful example. Also, what happens a lot in practice is that private companies, large private companies, tend to have very good databases, if you compare these databases to public databases, and they don't want to share it because they're going to lose their competitive edge vis-a-vis other commercial companies. And as a consequence, that has implications for the quality of diagnosis patients receive, because high-quality evidence-backed variants are not shared by some private companies, and some institutional solutions are necessary for that. And another concern I would like to briefly mention with respect to data sharing is that increasingly companies, not only companies really, also medical centers, are recruiting large numbers of patients for whole genome, whole exome studies, because this has very high utility down the road for patients, and they're looking into various associations with diseases, but they're not willing to share genomic data, raw genomic data with patients, so that patients can, or subjects of clinical trials, have the opportunity to reuse this data at a later time point if they need. So it would be great to stimulate this new way of looking at genomic data sharing, to provide individuals who have their genome sequenced with an opportunity to utilize their data down the road if they want to use for reproductive purposes later on, to see whether they're at risk of having a child with a severe disorder, or for optimizing treatment like pharmacogenomics, for instance, or for prevention purposes like in hereditary breast and ovarian cancer or diabetes. This could be used. It would be great to stimulate companies to share data with patients and subjects.
So caring is sharing, but how do we do the sharing?
No, if I might just add to the point that David just made, and I fully agree with you that there is a big challenge raised by the lack of shared data among commercial, but private actors, especially for the issue of commercial interest. And I think this is an instance of a broader problem, because there's a lot of discussion often about privacy in the context of biomedical data that presents it as a dichotomy between advancing science on the one hand and protecting privacy on the other hand, especially in the context of public health. And I think medical AI and especially medical robotics is one of those domains that show that this is to a large extent a false dichotomy. Because if you look at the behavioral data, we see that actually people with high standards and expectation of privacy are nonetheless willing to share their data as long as they feel in control, they feel they've been adequately informed about what the data are being used for, who has access to the data, where the data are stored, and so on, as long as they trust the data collectors. So trust is also key. And also, if they feel that there is some realistic benefit associated with the data processing. But if these conditions apply, people with high expectations of privacy are very much willing to share their data. And especially in the context of medical robotics, there is a lot of evidence that shows that privacy concerns among end users is a major cause of suboptimal adoption of these technologies. And as you know, medical robotics is affected by a problem of low adoption. And this is due to a variety of problems, including translational barriers that Robin has mentioned, but the privacy concerns of end users are one of these causes of suboptimal adoption. So there is really no interest, there should be no interest in proliferating these privacy concerns for companies that want to accelerate the translation of their products into the market. So I would say that the real dichotomy is not between advancing science and preserving privacy, but between advancing science and commercial interest by private actors. I see this as a real dichotomy today.
Yeah, I was, after you, I was thinking about, and after Vibeke, so what should we think about privacy actually? Because, and the companies, there is a company called Clear AI who have collected over 3 billion data about people who are on the internet. So probably if you are on the internet, your picture is there and your information is there, so you are in their database too. And so by combining different data dots, they have collected also more information and data about you. So they know quite a lot about you already. And if you have made a DNA test, for example, so maybe you have shared your information in MyHeritage, so there is more data points about you. And Clear AI, they have, for example, sold their database to the US police. So we are already all in that database. So I was just wondering that should we think differently about privacy, about, okay, I'm like this, is that private? So what are we actually, if you ask me that, am I willing to share my data about my genomics, I'm like, no, never. But then on the other hand, why not?
Which one? This. Can I just add to that? I think it's a sort of fun example to provoke a little bit. That a very short time from now, they say that you will have a pocket sequencer that you can just click onto your iPhone and you can sequence whoever you meet, right? So how private is really your DNA? I mean, okay, so it requires physical contact for someone to pick a hair or whatever from you, take your coffee cup, but it's still in a future not so far ahead. that will be a scenario. So I think we should focus more on how do we regulate the use and the purpose. It will be, I mean, it's already out there probably, and let's not be naive. So the thing is, how do we handle that?
Do you want to react on this, Robin? Or?
Well, I think medical privacy has been a norm in clinical practice in the hospital, in distributed clinic, for centuries, dating back to Hippocrates in 400 BC. And I'm actually going to read what he said, what was actually said back then. Whatever I may see or hear in the lives of my patients, whether in connection with my professional practice or not, which ought not to be spoken outside, I will keep secret, as considering all such things to be private. And we can think of that in terms of outside of the clinical practice, outside of health, is the move towards connectedness, towards linking health data, traditionally considered health data, with lifestyle data and all sorts of phenomenon. And as we go increasingly to this linking, these integrated systems, what kinds of concerns? How do we think about medical privacy? And given that there is a consequentialist dimension to privacy, we typically think of privacy as a deontological respect for persons type of consideration. There's a very important consequentialist dimension to privacy. That if people have the idea or think that their private information, their sensitive health information will be disclosed or somehow not be kept private, they may actually refrain from seeking health care. And I think that's a critical bottom line consideration when we talk about how important is privacy and how do we define it, et cetera, et cetera. It serves a function in clinical care. So if we don't pay serious adequate attention to this dimension, then we may actually be undermining our larger stated goals of providing and improving health care.
We have some time to have also questions from the audience. I want to invite you guys to be part of this conversation that we have. Is there anyone in the room that have a comment, a question? And yeah, feel free to come forward.
Thank you. My name is Magnus Stenbeck. I'm from Sweden. I think I have noticed that there is a divide between the authorities and the people that worry about privacy and the people who worry about medical ethics, really. And I wonder, part of the problem is that they don't talk enough to each other. How can we make the Data Protection Authority of Europe, for instance, think in terms sometimes of medical ethics?
I can comment on that with an example. I guess taking it back to our project, the legal group that we have set it up as a legal network where we include all stakeholders. So the Data Protection Agency, Directorate of Health, the Directorate of eHealth, the Ministry of Health, and all the different bigger health institutions. To have a platform, just a place to discuss these things, because it is so difficult and we disagree on so many issues. Well, we kind of do, but then after discussions we tend to get closer to one another. And our project is just for a certain amount of time, but we will continue this way of working through the Nordic Alliance for Clinical Genomics. And I'd like to invite anyone who's interested in this to join. Just contact me and I can put you in contact with the right people, because we want to expand this to a European level as well, because we see there are many common issues. Just as an example of how this has worked, this example I told you about earlier, this sharing of genomic variants and how the Directorate of Health had said, no, that's not legal. Are in this network, they developed a new way, sort of a legal discussion around how we can say that it actually is anonymous, And we ended up posting a genomic variant on our website, bigmed.no, with the description of why we think it's legal. And that went back to the Directorate of Health. They reconsidered, and now we're aligning nationally that at least that one thing we can agree on, and then we go on to the next topic. So there, it is a movement, but we need to talk to each other, and we need to have places to meet, and it needs to be not just the lawyers, but the lawyers meeting with the people who actually have the need to explain and go into details. Because, like we said, if you look at genomic information, everyone can agree it's sensitive. But if you go into the details, it's not always black and white, and we need to be really specific about the discussions we have.
Actually, I like very much like what you said at the beginning about the lessons learned. I think that in many fields, actually this makes a lot of sense also because also from the regulatory side, like we might not know everything at first, like, but maybe we can collect, like if we bring together also the European level especially, like, and then we also shared what did go okay, but also what did go wrong, I think, so yeah. Marcello, please.
Yeah, I just also wanted to comment to this great and very timely question, I would say. And I would probably also reverse engineer the question because you ask how can we bring the medical ethics to the data protection authorities. But I would argue we should also do the opposite, and probably we should do the opposite even more urgently. Because as an ethicist, I tend to see that research ethics in particular, medical ethics is slightly more advanced, but also, especially in the clinical research domain, we're really lagging behind the digital world. Our standards, which were very efficient standards that we developed for clinical research conducted in the physical world through approaches such as clinical trials and so on, doesn't seem to uphold in the context of this rapidly transformative digital environment where you can actually conduct medical research using no strictly medical sources and where you can conduct medically relevant research without enrolling patients physically in a study. There is plenty of research that you can use natural language processing on big data sets of social media posts, for example, to make quite reliable inferences about the mental health state of an individual. There is research that shows that, for example, you can infer the pregnancy of a person from Amazon searches. So, and this is also something that underscores a point that Vivek made, namely that in the big data ecosystem that we live in, we really need to focus on data uses and not on data types. I still also, when I give a talk, I also tend to say things like genomic data are sensitive data, and I agree. But if there's one lesson we have learned from big data, is that we can make privacy-sensitive inferences from known sensitive data, and this is something that we need to take into consideration. And soon, in the next few years, I expect that we're going to see more and more of these privacy challenges. So, for example, making inferences about a person's mental states or emotional states from emotional AI, face recognition, and so on. So we really have to be mindful that we need governance models that are agile and adaptive enough to make sure that we can look at the inferences that are made on the data and not at the specific data types. And on your point, yeah, we need to do that. In Switzerland, we are working together with cantonal ethics committees in order to understand how they're actually assessing and evaluating big data research in the healthcare context. And the short answer so far is they don't. A lot of studies, the large majority of studies in this domain, they just bypass ethics review because they assume that the data that they're using, they are publicly available if they are from publicly available online repositories. To the extent that patients are not physically enrolled in the study, often researchers bypass ethics review, especially if the data are anonymized. So this really shows that we need to have more agile ethics review mechanisms that can take into account these new ways of doing research in the next few decades.
Yeah, I was thinking about what we have approached maybe a little wider reply to your question, we have approached that we also need to take in consideration those people who are impacted by this data. So we have included people from different areas of business and the society, for example, the municipalities and municipalities' health sectors, different experts, third sector, professional unions, government, the social security, different instances, the system, and also citizens. So we have had hundreds of people discussing the program, what we are working on. And at the moment, we are also reaching out to globally and to the international society to help us develop more, and also if we have something to share, we would love to share. So I think that everybody should know, and in the panel before us, there was a very good point made about the data awareness, that everyone should be aware about this data, about AI and everything. In Finland, there is a huge discussion about ethics of AI at the moment and data, but I'm afraid that it's only inside a certain bubble. For me, it seems that everybody is talking about it, but actually, I think when I go out from my bubble, no one is talking about it, and I think everybody should know about this.
I agree. Is there anyone? Yeah, can you come forward, please?
Hello, my name is Alexandra Ebert. I work for an Austrian startup that does synthetic data, and I'm standing here because the charming host of this panel asked me to bring the topic of synthetic data up. And my question is for all of you who are not familiar with synthetic data. It's a way to anonymize data where you can retain all of the valuable information but make re-identification impossible. And we help government organizations, insurances, healthcare organizations to make realistic synthetic data available to researchers and other organizations. So my question to the panel is, why are not more organizations in healthcare using synthetic data to facilitate AI innovation in the healthcare domain? Thank you.
Thank you. That was a great question. I don't know which one of you to say thank you to. So we've had that discussion a lot, actually. It actually seems that the clinicians are the ones who are most skeptical to this, because they don't see, they want to see real patient data and relate to that, and they're afraid that they won't get the right results, really. So they have been the ones opposing it, whereas our data scientists, they've created synthetic data sets and sort of playing around with algorithms, and you can do that, I guess, in an early stage, but at one point, I think for the clinicians to believe in what you do and the validity of it, you need to use real data.
I think this is very, very, very important, because in healthcare and in other aspects of life, for example, in traffic, there are many things that we need to simulate before we actually do things. And for these simulations, synthetic data is really crucial. And I'm so happy to see this industry widening.
Very short point from Viveke.
How much time do I have? 1 minute.
20 seconds.
20 seconds. So I was... the AI and how we can trust it and the patient safety around it. I mean, we have the CE marking, we touched upon that earlier. We have some regulations in place, but really this needs to be a risk-based approach. So we've talked about, and in several other panels, that the criticality of it is where it's used, right? If it's an administrative tool, it's not that big of an impact. If it's something assisting you eat, well, if it malfunctions, okay, but if it's operating on the patient, it's more critical, right? So it's about where it's used, but also I think it's about how it's used. And I just had this idea when you were talking about, or more of you about robotics, that in my world, when we create clinical decision support software to put into the medical journals systems, the interface of the clinician and the way they use and sort of interact with the system will influence a lot of their decisions. And there's just not enough activity going on that. And we've been looking for someone working on that. We have not yet found them, at least not in Norway. So if anyone has anyone or knows of it, it would be good. But my idea was that I think when it comes to physical products, then that's an integral part. I mean, it's just always a part of a product design, and we should bring that into what we do as well. So I'm going to bring that home with me. Thank you.
So we have just a very short time that is keeping us from the lunch. I will just ask the panelists for a final message. Like, what would you tell to an audience that they're, I assume, of course, interested in healthcare, but they have come here to the conference of CPDP? What would you tell to them as a takeaway message from what we've been discussing here? We will start from Marcello. And then we will. Go. Yeah, you have the microwave. The microwave. No, the microphone. I'm hungry.
This is fun.
Sorry.
Go. Before the panel, I told you that this was going to be the most fun panel of the conference, and I think we're. Yeah.
Well, I won't ask the audience just in case, but thank you.
So, very quickly, my main takeaway. For today would be that the surge of genomic revolution is coming. A quick fun fact, more than 500,000 people in Europe have already their whole genomes or whole exomes sequenced, and this will only accelerate, and we have to prepare to deal with this in a responsible and accountable manner.
Thank you.
I would like to, because we started with the negative example of a telepresence robot, so I would like to tell you a short story about Yusuf. Yusuf is a Danish guy, he's about 13 years old, and he got some disease that prevented him from going to school. And this is the story that put me into tears when I was in Helsingør in Denmark and I heard this story from his teacher. So Yusuf couldn't go to school, and so what the teacher did, because he was aware about the robotics and what they could do, so they decided that they will invest on a telepresence robot so that Yusuf can still go to school and still meet because he couldn't meet anybody. It was some kind of immune disease. So he couldn't go there, he couldn't meet his friends, and so he showed us a video how Yusuf participated in school. He could look at the pictures, look at his friends, go out with his friends, be involved all the time in learning. And so comes the Lucia Day. In Nordics we have this Lucia Day when we celebrate Lucia, the saint woman. And so they decided that they want Yusuf to be Lucia. And so the entire class, they participated in planning this Lucia Fest, and they put this telepresence robot, had the candles in its head, and Yusuf was there in the robot and was leading the convoy of students. And we were all crying when we saw that. And it is so fantastic. And doctors had said that Yusuf will die within 2 years because of this disease. But he's still living, and it's 5 years now. And we think that it is because of this robot that he really can, because these friends mean so much to him. And this is what we should be doing, because inclusion is something that we cannot think about enough in this world where technology can take us apart from each other. And caring about each other is more important than technology in the end.
That's a wonderful story.
It's really mean to let me talk after that, because now I'm just crying. Wow. That was a great story, and a very positive one. I think my message would be, in healthcare, it's very complex. We have all the issues around data. It's just not good enough. Things are uploaded in PDF. We need to start working on sort of the first step before we do the fancy AI stuff in the hospital. So it's a little bit back to basics. It's a boring message, but it's unfortunately true. We can do both at the same time. Also, we need to experiment more. We need, as Robin touched on, how research and the clinic are moving closer to each other, and we need to facilitate that in a good way. We're not there yet. So we need sandboxes, we need to experiment. Now, the Norwegian government just issued a strategy on AI. Finally, we came after you. And they emphasize regulatory sandbox, which I think is a great idea. We need that. They also allocated a fjord for autonomous ships, apparently, which is cool. So we should allocate a hospital as well.
Just very quickly, I agree with everyone, what people have said prior to this. I'd just like to emphasize the translational process as a multifaceted consideration. It's not consideration, does this technology perform better than a doctor? It's not just, one particular inquiry. It's a wide range of inquiry. It considers the broader impacts. And so I would go back, actually, for example, to something that Julia Powell said on the panel yesterday, that when we do these, predictions, et cetera, risk predictions, et cetera, prognosis, diagnoses, that this is based on the information of a lot of people, not necessarily that of the individual in front of you. And sometimes that's fine, but sometimes it's not. And in the case of healthcare, when is it not? And with what consequences? How can we address this in the context of healthcare? The people have talked about labels as a possible solution. That seems something worth pursuing. But that's the kind of inquiry that I think really needs to be emphasized. And to always ask the question, who is being left behind? Who is advantaged by this technology in this application? And who is disadvantaged?
Well, it's very hard to add anything meaningful after this fantastic closing remarks by my fellow panelists. Probably I'm going to say one last thing, which will sound probably pretty trivial, but AI is here to stay. It's not going to vanish away in the next few years. And it really holds the potential for transforming or even reshaping healthcare as we know it, in terms of better diagnostics, better prevention, better assessment, and better technology. But these fantastic promises that are ahead of us might really risk to remain underexpressed if we don't address right now the very pressing ethical, legal, and social challenges that are associated with the use, the design, and the deployment of artificial intelligence in healthcare. So it's very important that we do this now, and I would like to emphasize, since we are at the privacy conference, that addressing issues of privacy and data protection is extremely important in this context. We need to protect data in the context of advanced medical AI, and this is something important to do not only per se, but also most importantly because protecting data is a very good proxy strategy for protecting people. And at the end of the day, protecting people is what matters in medicine.
Thank you. So my message to all of you is to share something that I wanted to be more present in my 2020 and I hope like my life. It is just a very short and sexy sentence, which is make kindness the norm. And if we have this idea in our background, I'm sure that we can push more towards like the potential benefits that this technology can bring us to society, while at the same time ensuring that all the users' rights and all the different interests are equally evaluated. So thank you so much for everyone. If you have any question to the panel or to the panelists, just be in contact and just enjoy the lunch and the rest of the conference. Thank you so much.